It doesn't spell out who we're at.
Gotcha.
Yeah,
I see it. I didn't.
Oh, I need to have. I need to have this over here. I can't see it.
Oh, okay, so you want me to, you can open the meeting, but before she needs to, just go to the on the board. If they're gonna be up here. Oh, I was like, I don't think I've ever been to a meeting without you.
Is it right here?
It's just Sue. Yeah, is it just Sue? So far?
Right now it's Sue and participants, some county employees.
Okay, so it's just Sue we need to.
Is there a way we can get like everyone on screen?
If they share their camera, I can only do it if they share.
Okay.
Let me pull this over and take a look.
Because usually it shows like participants.
Yeah, let me see. Hold
So
on.
I know like.
Okay, Kenya's here as well. Kenya's here also. Let me pull it over. This is really, I have to pull it over to read anything because I can't see that screen. Hold on, people keep joining. Hold on. Okay, let's see if we can do. It's on gallery. And it says show non-participants, so that's as much as it's showing. Immersive will look different. We don't want that one. Yeah, it's on gallery, so.
Okay, it's just everyone's off camera.
What is that?
Hide selfie, which we're not doing. Show non-participant. There you go. It came up.
Cool, awesome.
I fixed it.
Yeah, just to see like who's there.
Oh my gosh, I'm so blind. Okay. I believe we are recording there.
So.
Okay, you can begin whenever you're ready.
Just leave from last meeting? No. Okay. Which is just, so Ken and Sue are going to. Yes. Okay. So we just need to. So, Sue, can you hear me?
Yes, I can hear you.
I just want to let everybody know that you are participating as a voting member, and that you'll keep your camera on, barring any, technical difficulties, and that you, if anybody's in the room with you, they are under 18. We have nobody in the room with you over 18.
Yeah, there's nobody in the room with me.
Great, thank you.
And then
Super, Kenya? Yes.
cool. Okay. Hi, Kenya.
Yes.
So you're participating as a voting member, correct?
Yes.
Okay. Ideally your camera would be on, and then if you have anyone over 18 in the room with you, you need to notify the chat.
She's not. She's not.
No one's in the room with me.
Okay. Okay.
You can have children, but not adults. Because technically, then they're participating. The Brown Act.
Can everyone on Zoom hear us? Okay.
Yes.
Yes. Yeah, we can hear.
Yeah.
And then question is, Emily, welcome. Are you providing the Board of Supervisor update tonight? You're on mute. You're on mute.
I am representing Supervisor Frex.
Okay, so you'll be doing, okay. Great, thank you. Okay, and then I don't know if you want to just do. I'm just gonna- yeah, sure. Okay. All right, so now you're gonna call the meeting.
Okay, I would like to call this meeting to order at 6:06 PM. So before we move to agenda approval, I'd like to welcome members of the public. There's going to be opportunity for public comment. So, members of the public can speak either in person, which we have no one here, or on Zoom. You're not required to identify yourselves. We open each section of the agenda with an opportunity for public comment, so there will be multiple opportunities to speak throughout the meeting. You can always ask questions in the chat, and we can get to that when it's appropriate public comment time. In compliance with the Brown Act, no action or discussion will be taken on items that aren't listed in the agenda, which is available on the Yolo County Local Behavioral Health Board website. However, we may ask for clarification, or we can refer concerns to staff or request that an item be placed on a future agenda. So now we move to approval of the agenda. I now move to approval. Do I have a motion to approve?
So moved.
All in favor, say aye. Any opposed?
Who's second?
I did.
Okay, thank you, Megan.
Any opposed?
Okay, I'm going to begin roll call for those who are participating online, just so I can get your votes. Sue Jones,
Aye.
Kenya,
Aye.
thank you.
So now we're gonna move on to approval of the minutes. Do we have a motion to approve the minutes?
Moved.
Okay.
Thank you.
Any opposed?
Sue
Aye.
and Kenya, this is for approval of the minutes.
Aye.
Thank you.
Motion carries. And, okay, so we have a new board member today. If you want to just welcome to the board. When you have time, we can do offline, do Kimberly's onboarding, but if you want to just like introduce yourself to the board.
Yeah, well, my name's Kingsley Melton. I've lived in Yolo County since coming to Davis as a young man. And I bring just a variety of experiences to the board. So, I actually wrote my dissertation for my master's in business administration on the Yolo County Indigent Healthcare Program at the time, YCHIP, and the cost drivers. I also spent a decade in the classroom, mostly in front of high needs high school students, family members that are customers as well. And I have a wife that's an RN that spends less time now, thankfully, in the ER in South Sacramento, and can attest to the behavioral health needs that she sees on the regular. So, I have a good vision of kind of, I don't come with zero. Thank you. Happy to be here.
Okay, thank you for that. Do we have any member announcements?
I have a quick member announcement, just because I thought it was fitting. The call I was just on that I had to take, so I apologize for that. And this is, a problem we're seeing, and it was a problem with someone else who's in our space tonight. Drove over with Chris, and we prosecuted a young woman who had committed some pretty significant crimes, and we, the DA, really fought hard to try to give her a different pathway, whereas a lot of our partners were not willing to because of the nature of the crimes. And it turns out part of her mental illness was due to being human trafficked. So she ended up, her mom, to her credit, and her attorney got her into a program in Riverside, and there's a lot of funding for these residential programs for human trafficking victims, fortunately for them. And she just did amazingly well, and this has been now a couple of years since she's been in this program, to the point where she's in leadership positions and now she's looking for employment. And here's where the problem is. I still keep in touch with her mom for a little bit. And when she applied for a job where she needed some fingerprinting, so it was like a government type of job, I assume, they're seeing a conviction, which is contrary to how we resolve the case. We resolve the case really carefully in a way so that she would have a clear record and a second chance. And that's not what was happening. So she was rejected from a potential employer, and they reached out to me, and I reached out to the court and through a contact at the AG, because they're the ones that should be clearing the rap sheet. And so I've been playing phone tag with a woman at the AG's office, and she was supposed to call me at 5:30 today, so she just called me. So she's going to work on it, and she's even willing to talk to Ashley. Ashley is the young woman who was prosecuted and was doing so well, to try to help her through this. But it's a problem not only with this situation where you'll see something on a rap sheet that shouldn't be there because it wasn't taken off, but you see situations with people where employers are looking at the public record and what they see on the court's website. And it's misleading or not clear, and they're thinking that something they're seeing is a conviction when it wasn't a conviction. And when I see the couple of instances where it's come to my attention and we've helped out with people like that, it really makes me wonder how many people are out there that are facing that same issue that don't know who to go to or don't have a contact, which makes me a little bit sad. But anyway, so hopefully we get this situation fixed for Ashley and she can move on with her life.
Thank you. Other member announcements? Any board members on Zoom have any announcements?
No.
No.
Correspondence.
We had correspondence received and noted as the wellness report. I did not include it in the packet because of the size of the document, but it was included in the link with the information you received online, and it is available online for you to read.
You can have any questions or comments
On to Board of Supervisors report.
Hey there, I just have a short little bit to complement, hopefully, Tony's more detailed report. Basically, at last week's Board of Supervisors meeting, staff shared that as Yolo County shifts from MHSA to Prop 1 BHSA, even though there's a projected revenue that will increase 19.4 million in fiscal year 26-27, new rules mean that we're still going to need to cut about 2.3 to 3.3 million, mainly in non-early intervention BHSS services, while shifting more funding toward early intervention and higher need populations. And I just want to speak for Supervisor Frericks. He is really focused on protecting our strongest prevention, early intervention, and crisis co-responder work. And that's it.
Thank you. Thank you for the update. So under the time set agenda, just updates.
we're expecting you to hear them.
I was gonna say, we're early,
Yeah.
you know, we're ahead of schedule, you know.
Welcome.
This is, I mean, this,
Smarter than
this-
you even
from my perspective, this is the board's meeting and I'm here as a guest, so I will speak when you're ready for me to speak.
Are you okay with just pausing?
100%, yeah.
I'm gonna close this just so that we can hear Tony speak.
He's quiet.
Oh, okay, I mean, I think I misunderstood. You want me to start now and then
Were you okay? And then we need to.
when
Speaker
you
five,
when
we'll
pause?
talk.
Okay,
Are you okay with that?
that's fine. Yeah, I thought you were saying other way, like we told Nikki it's,
Oh,
you
no.
know, okay.
Thank you.
Okay, well, I appreciate the opportunity to talk about the budget as we were just hearing a moment ago from Emily. We are anticipating some challenges with the behavioral health service back funding, but I'll get to that in the context of sort of the bigger picture. So in the behavioral health director's report, 9B, I did provide a brief narrative snapshot of the challenges that we're facing. So at a county level, the county is anticipating approximately a $27 million deficit or $20 million deficit in general fund availability in fiscal year 26-27, that could potentially increase to another 47 million by 2031. And that's an evolving situation. As every year as the county gets in budget processes, the numbers kind of start moving around. But it's a pretty big number to start with, right? And so the CAO's office has directed the different departments to start looking at ways to reduce general fund liabilities. And what Health and Human Services, we're looking to make approximately a 15% cut, $17 million, which is somewhere in the neighborhood of $2.5 million, right? So the way it's currently projecting out for behavioral health, as we're looking at it as an agency, behavioral health will need to make a cut somewhere in the neighborhood of $1 to $1.5 million. We're still kind of working through some of the process right now. Behavioral health doesn't receive a majority of its funding from general fund. We do receive I want to say $2 to $3 million in general fund funding, but normally most of the funding is for what we call a maintenance and effort requirement and their funding. And it's not like a primary source of funding. It's still just making like a one cut to jump to overall programming. This is something that we're looking at. The bigger concern is around 1991 and 2011 realignment. So these are local dollars that flow from the state through vehicle license fees and sales tax revenues. And that number, just like any kind of funding source, fluctuates a little bit from year to year. And we are anticipating a decrease in that funding. And we are looking at making approximately $2 million of cuts across both of those funding sources combined. As Emily referred, we do have an increase in funding, the base allocation for Behavioral Health Service Act funds from somewhere like $15 million last year to about $19.4 million this year. But just sort of the way that you have to move to fund specific situations. Our initial estimate was somewhere in the neighborhood of $2.3 to $3.3 million deficit, just by the way that we're looking at the cost of having like a structural deficit. But we've been working on it over the past week and as recently as today, and I'm not ready to say just yet. But what I can say is with regards to the Behavioral Health Service Act funding, based on the work we were doing on it today, it looks a little better than what I thought it was going to be. We believe we can shift some of our costs from the non-early. We believe that we can just shift some costs that we had allocated for behavioral health services and supports over to early intervention, which kind of falls out. And I can explain that in a little bit more detail in just a moment, right? But big picture is that we're looking at somewhere in the neighborhood of $3 to $3.5 million cuts in general fund and 91 to 2001 all total combined. We will have some kind of a structural deficit issue likely in the Behavioral Health Services Act budget. But we also have $12 million of fund balance in VHSA, right? And so what we'll do is we'll put together a presentation for the board's consideration, right? How to use those. The challenge that I was talking about with the VHSA budget in particular, just kind of get into a little bit more granular detail, is that we're supposed to take the allocation. 35% is supposed to go to full service partnership services. 35% goes to what's called behavioral health services and supports, and 30% goes to housing. You guys have all heard about the housing fund. The FSP portion, but we have a general plan for that we don't think that's going to present. It has its own challenges, but it's not creating the budget challenges necessarily for us. And housing is something that we're just programmatically need to figure out how to stand up and put together. The issue with behavioral health services and supports is that in that bucket of funding, right, which is 35% of $19.4 million, $6.8 million. The issue is that 51% needs to be spent on early intervention. So we had crosswalk over some existing costs from our Mental Health Services Act plan that fall into that bucket that were not early intervention, that were approximately 4.9 million. So we start doing math, like half of 6.8 is 3.4. If we have $4.9 million of funding, that's $1.5 million over 3.4, right? And we would have to match it on the early intervention side. So every dollar you spend in behavioral services supports that's not early intervention, you have to match it, right? And so that's where we were coming with this figure that was approximately $3 million, right? So I currently believe that we're going to be able to move some of those costs over into early intervention, which is going to start to even things out quite a bit. The bigger question is going to be, what do we propose to do with the fund balance? And how do we offset some of the potential cuts that we will be making because of the reductions in general fund and realignment? So I will pause for a moment. I'm sure you all have some questions about that and try to clarify what I can.
So can I just ask like a general kind of question?
Please do.
Like, so what I heard was a very administrative heavy report, but without kind of a connection to kind of like, I heard broad brushstroke, but what is that translating to as far as like what you're looking at? Like when you see, what I didn't hear is it's like, the board asked you to consider cuts. What I haven't heard is, what cuts are you considering? I've heard about a lot of shifting, but like, and maybe this is premature and
It's definitely a fair question. So I appreciate I do appreciate the question. So for example, there's some administrative maneuvering, I think is probably the best way of putting it, right? So for example, with our realignment, there's some pieces where we're like, okay, hold on a second here. We had a grant, then the grant went away, and we were using realignment to fund it. We're getting the grant again. That's kind of thing up some of the costs there. Right? So there's some parts of like kind of reorganizing the revenue that's reorganizing revenue that we're anticipating receiving and kind of cleaning up the budget to address it. The reality though, right? Like, okay, so eventually something has to get cut, right? And we already, the prior fiscal year, made a lot of drastic cuts. We made cuts to the alignment, and I can't remember the exact figure, right? But it was millions of dollars. And then we had an $11 million structural deficit, the MHSA money. And we cut $11 million of program at that time, right? And we also cut like just about everything that you would think to cut that doesn't affect direct services, conferences, unnecessary travel, any type of anything that we don't, that isn't actually critically necessary. Ultimately, the and we cut some contracts, right? There were some contracted providers who were affected last year because of the cuts to NHS. One of the biggest expenditures that the county has is employees. Staffing tends to be the biggest expense, right? And because of all of the budget cuts that had to occur last year, and because of stuff that was happening at the county level, and the hiring freeze at some point last year, we had eliminated some positions last year, and we've been holding positions vacant this year, right? That we're budgeting for. And administratively, right, we get into some decision making around, okay, like at some point we have to start eliminating some of those costs, right? And so you start to make decisions about filled positions, right, versus vacant positions. And I'm confident at this time that we can likely make things work by eliminating vacant positions. And we're not completely there yet. And of course, it's not my decision to make ultimately, it's the board's decision to make recommendations to the board, right? But I'm confident that we can recommend a budget that would not affect current employees and significant reductions to contracted services. Yeah, right. However, what that means is that we've been running with a skeleton crew for over a year, right? I have, 5 major programmatic areas with managers. 4 of them don't have supervisors. We have lost clinicians. We've lost case managers to natural attrition. We've had difficulty recruiting for psychiatrists, right? And these are positions that we would likely eliminate, right? My YOLO counties, right? They're not mine, right? YOLO counties, behavioral health employees have done a superb job of navigating this somehow, right? Last year, we had, as you all know, a contract that did not renew, and we absorbed 207 FSP clients into the internal system care with no additional staffing. And so, my point here is that's where we'll likely go.
Thank you. You
Yeah.
answered my question
Yeah.
and then some.
Sorry.
No.
I didn't mean to
I don't want to drag all you guys.
You gotta catch up.
Yeah.
Ask the
So
questions.
I appreciate it. Thanks for being patient.
That's okay.
Staffing issues are happening in terms of not backfilling. Do we have the same amount of people to serve every year, or will we, what are we gonna do if we have to increase in like any more beds, so with all these cuts, does that mean that everything's gonna kind of stay as is? And there's no room for more services that might be needed, like under SB 43 or 34 or whatever that comes out in the future?
I think that the short answer is probably not, right? I mean, I just being a realist, right? I don't see how we can expand services when we have contracting budgets, right? Now, that does not mean that there are not opportunities, right? And one of the pieces that has been difficult to quantify, right, is the degree with which we are not generating the kind of revenue that we could generate as an entity that can go from Medicare, right? And so part of that is on a programmatic level with the actual staff who provide the services, and part of it is a systemic issue. And we're working on both issues simultaneously. But it's not going to be something that happens overnight, right? The other part is what I think probably everyone knows, and I think that Supervisor Ferris would attest to it, right? Is the degree to which we can intervene and keep people out of hospitals, right? Will free up some dollars, right? Because that is a huge expense, right? Paying for individuals who are in hospitalization, paying for like a higher intensity of care, is also just a significant draw on the budget, right? But you get into this kind of, you're talking in circles, right? We need staff to implement a prevention program, people call the hospital to free up revenue to have staff to right, so what I feel like right now is that we are contracting, we're looking at like how we can reorganize as a behavioral health system and maintain the current level of services that we have, and then we're going to just navigate it as we look at do something. I mean, it's terribly unfortunate, right? I mean, it's terrible.
So,
That being said, there's also, we do have $12 million fund balance, right? So the question is really what are the county's priorities, right? And what does the board want to prioritize? I know that I am very reluctant to advocate creating another structural deficit, right? What we went through last year was incredibly difficult. And so you don't want to stand up stuff for a year or two and exhaust the analysis, and then on the other side of that, now you're having to cut everything, right? And we're also looking down the road, as you see, the county is down the road is looking at some challenges, right? So it's really going to depend on what the board prioritizes, and I think to whatever degree this board can inform the board of supervisors what we feel their priorities ought to be. That's something.
I have a question on the board because you're here.
Oh, sorry.
Yes, you can.
I'm so sorry. I went to the Arthur Turner branch. I was sitting in the parking lot waiting for it to be 6:15 so I could come in. Then I looked and saw it was some other meeting. So I'm sorry.
Better late than never.
Yeah, story of my life.
Well, I'm sad to see you go.
Well, I have mixed feelings about going. I'm sad. I will miss the incredible range of experiences and understandings of mental health issues that this board has represented. It has been truly a wonderful learning experience for me. I have been a family member, someone who was severely mentally ill for many years until he passed a couple years ago. And I got a chance to see what the department really functioned like. I could see from the outside when I had frustrations or when I wondered why X didn't happen the way they said it would, or why it didn't happen the way they said it would. And I really had the opportunity to learn a lot. And I think it's going to help because I talked to many people who have family members who are ill. And, I've had them curb their expectations because nobody's going to take this burden away from them. And that's often what they're really looking for. But I've taught them, I think I've told them that there's hope and there's a way you can work through this and just hang in there. So thank you for the opportunity to serve.
Thank you. So I know you've served for many years, but I couldn't find exactly when you started on the board.
I started in January 2013.
Oh, wow.
So I said today it had been 12 years. It's actually been 13 because I finished up somebody's unexpired term.
Wow.
And
that's amazing.
so,
well, it's been an honor to serve with you. We have all learned so much. We find you such a wonderful mentor for all of us, and your voice for so many people that need one. Yeah, which is amazing. And yeah, it's rough. First Maria, now you. Yeah, a little choked up here, but
I've become really a true advocate for the kinds of services that we provide here. And I am thrilled because we are providing them for a much more diverse audience of consumers than we were 13 years ago. The county was at that point 56% Latino. And we were serving somewhere in the neighborhood of 12%. So it has changed a lot. Word, thank you, thank you, thank you. Oh, these are beautiful. Lovely, thank you so much. I've had a wonderful time and looking forward to seeing who the supports next. Thank you.
Anybody have anything they want to say before she scoots out, or?
Yeah.
Thank you so much for your service on the board, and it's kind of been great to like have the mentorship and guidance and being on the board.
That's another way of saying I'm boss. But thank you very much.
As the new veterano here, now you're leaving.
Yeah.
Thank you so much, Nikki. Enjoyed serving with you. I think with you on this board, we've accomplished a lot before I got here and a lot since I got here, and we're gonna do a lot more. So the future is bright. Times are tough, but still,
Yeah.
I think we're relentless forward vibes.
Getting better, even with the funding now. I think we've got opportunities to do things that we didn't have several years ago. So don't give up the ghost. At some point, we're going to be able to implement a full crisis now. But we'll get some training on how to do it on the cheap in the meantime.
Yeah.
Anybody that has to or?
Nikki, I just want to say, I think your historical perspective was really helpful, especially when we're coming out of the COVID, meeting in person again for how things were done before COVID, as we got back up and moving. I want to thank you for that, helping out.
I truly enjoyed it. We're a great group of people here for the right reasons. So thank you all.
I think there's some people on Zoom that might want to say something as well. We'll open it up. Yes.
And of course, my glasses aren't allowing me to
That's
see
okay.
this because I don't have distance correction.
So we'll open it up for public comment.
Yeah, I just wanted to add my thanks, Nikki, and my appreciation for the perspective. You always have such great ideas, and it's based on just your deep knowledge of the county and of mental health. So thank you very much.
I just wanted to say on behalf of Supervisor Frericks, thank you for your service on this board, Nikki. He's really appreciated having you on it.
Didn't know until he told me that my term was up. Because I've been counting from the first time I was appointed as opposed to the last time I was appointed. So, but I'm truly good with it. No, I mean, it doesn't mean this isn't something I love, but you know, time for somebody else to have a good experience.
Don't be a stranger.
I won't.
Nikki, I also just want to say thank you first of all, I appreciate your passion and candor. And I, recently, been meeting with you in the Save Pine Tree Gardens committee or what Thompson Walker.
No, it's Thompson Williams.
Thompson Williams committee, sorry.
Yes.
My bad. It's just not fascinating, but it's just, it made a really deep impact on me, how much history there is in Yolo County of like kind of grassroots type advocacy of like just concerned citizens and family members who have like really poured their like heart into building a system of care, right? That government didn't necessarily do, right? And I got a really deep respect for that. I think you guys have heard me say before, like, I'm getting paid, right? But you guys are all here on your time because you care so deeply about what's happening. And I think that that's really embodied in you, you know, and I also just appreciate, invested into this.
Thank you, thank you. I want you to know, I came from Los Angeles County where we had worked on getting my family member services for many, many years. He got better treated, better served, and on better medications within the first 6 months of being in Yolo County than he ever did. So, I mean, I think it says a lot about Yolo County and about the kind of outreach this committee has. It's a real hierarchy in LA about the local mental health board, local behavioral health board. And so if you can't figure out who to even talk to, it's pretty tough. So thank you very much. I love you all. Give me a call anytime. Anytime there's something the minutes don't have recorded. I may have it in my brain.
Thank you.
Thank you.
Drive safe.
I will. Bye-bye.
We just to stop talking about the budget.
Was there anything?
So maybe we could pivot from what's maybe not going to be, but maybe is there a silver lining with respect to innovation or pivoting, or maybe some thoughts you guys have about maybe doing something a little different? So, you know, sometimes there's a silver lining when we have this.
Yeah. I mean, I think that the potential silver lining is that we're at a point where we're going to have to do some sort of reorganization, right? You know, and so I think that it's an opportunity for us to look at the system and figure out, okay, what the pieces we have, how do we use them the most efficiently? There are also some elements of the Behavioral Health Services Act that requires us to implement some evidence-based practices. So there's ACT-BACT, early background services, and there's CSC for FEP. It's a early intervention program for substance psychosis. And so those are things that we will be standing up as part of the necessary requirement. There's also, I believe that there's a potential opportunity in the county with implementing a different electronic health record, right? You know, so as you guys recall, I talked to the board about using innovations funds. The board of supervisors had approved it. There was a delay because there were some questions about procurement processes, but it seems like we have this resolved and hopefully we can move forward. You know, we've heard positive things from other counties about how the implementation of that particular electronic health record with revenue cycle management has helped it to increase Medi-Cal billing and revenues, right? Also, I think that it just kind of creates an opportunity for us to reorganize the system of care using that electronic health record as a framework. Again, this is something that's like a multi-year project. It's not something that, but I'm optimistic about that in the future. We're also doing a lot of administrative work to get a better understanding and to reorganize the way that our budget is established, because it's been difficult from a budget perspective to perform all the plots. And so we're investing in significant, especially as it relates to the VHSA reporting with the public voters. So, I mean, it's not all bad, right? But the silver lining, I think, is just much like, you know, how you're all praising Nikki and all of the other individuals who have really been passionate, dedicated, but we have staff, you know, and you know, I'm optimistic that we will find a way to make it work.
Do you have a timeline? Are you guys working on a timeline in terms of, for example, like the Medi-Cal billing?
I mean, if it can really bring in funds, because we've been talking about that for like a year, right, like a year ago.
We've
been talking about it.
more than a year. I think.
Yeah, I mean, is it being implemented? Are we saving money, or is it something that's gonna happen? We're gonna continue to work on that.
It's there. Well, there's multiple parts of it, right? So I mean, so one of the great things that has happened recently is we have a new assistant director and seven who returned to the county, and one of her like just walking in the door, one of her primary assignments is to look at what we need to do to increase medical revenue from a systemic perspective, right? So there are things that are happening, right? One of the kind of offsetting challenges is like you can't generate as much revenue with fewer staff, right? But you know, it is what it is. But I think that what I would say is that my perspective is that it's going to take a few years to get to where we need to be, and as a behavioral health system. So yeah, I don't necessarily have a specific timeline at this point.
So when you say staff, so am I assuming that Medi-Cal doesn't become FTE neutral, meaning that you can't pay, Medi-Cal will not cover the whole cost of your clinicians?
No.
Or the services you
Yeah,
provide?
no.
It's just, it helps.
So I mean, the challenge is that when we're doing Medi-Cal billing, you know, essentially we're using a dollar to pull on a dollar from the federal government, right? So even, I mean, you would have to have staff billing like 100% of the time, right? You know, they have to have no time that they weren't billing, right? And that's just right. But what it does, what increased Medi-Cal billing can do is it can offset the cost. It can defray the cost for staff and allow you to have more staff to provide. It's not completely, yeah, it's not completely, it's never going to be completely cost neutral, but it can help reduce the cost.
You might be able to increase services. Not, it won't.
Yeah.
Is there an estimate as to how much Medi-Cal billing is being missed?
There's some complexities around that, right? That, but I'm working on that as well. I mean, part of that, one of the big challenges, like an example, is Medi-Medi billing. So at one point, the county was able to bill Medicare, right? Because Medi-Cal is the payer of last resort. So if an individual has both the Medi-Cal and Medicare, you're supposed to attempt to bill Medicare first. When you don't do that, Medi-Cal won't pay, right? So if we have many clients and we're providing them services, we're not getting any reimbursement, right? Well, for one reason or another, the authorization to bill Medicare had lapsed before I was here, right? And we're working to get that. We're working on that reset. So that's one example. There's other things that the county has historically not elected to do that we're also working on. There's like Medi-Cal administrative activities, Medi-Cal for some of the administrative work that's being done. It's complicated and there's like a lot of hoops you have to jump through. But it's like, it's millions of dollars, right? You know, and so for one reason or another, we never approached that before, right? And we are now, right? So we have a consultant who's helping us stand some of that. So there's a bunch of different efforts that are happening. The other real challenge, I mean, just to be, you know, honest, is that it has been difficult to get information like for this board, because of data, right? From our existing electronic health record with the way that it's organized, right? And we've had we've also had some challenges with getting up-to-date fiscal information that will help us to inform like some of those things. And we're working to reorganize all of that as well, right? So the short answer is I could get that answer. The more nuanced answers, it would take a while to get it, right? And that's part of the problem that we're trying to fix.
The EHSA funds are $19 million.
So
So it's gone up from 15. We've been looking at a downward trend on income, my recollection.
we're surprised, right?
Okay.
However,
I was just gonna say, is this,
you literally can't make this stuff up, right? So they're going to give us revised projections tomorrow, right? So, tomorrow, I could be saying something slightly different, right? But those numbers sort of fluctuate, right? And it's an estimate. So there's a fellow at the state, his name is Mike Geis, he's sort of the subject matter expert in calculating out for the counties what the VHSA, MHSA, VHSA revenues and realignment revenues are going to be. And we received some projections in December, and we're about to receive some revised projections tomorrow. So depending on what numbers are put out there,
for new members' benefit, MHSA now BSHA income is going up consistently until recently where it went down. And now this recent bump up seems to be a surprise. As we'll find out tomorrow, if it's expectation that will continue or not.
yeah.
That's good news.
And so as you know, it's a 1% tax on millionaires, right? And they did great during the pandemic, right? And so the revenues went up and then they sort of just fell off. Right? So we don't know if that's just an anomaly or what. So that's part of the problem with MHSA funding is that it's just kind of up and down. And the state has talked about working to help to resolve that issue for the counties, right? By kind of doing like a buffer, right? Like 4 or 5 years kind of evening it out, but that's not something that has actually happened.
Do any board members online have any questions or comments?
Maybe this is completely off base, but I just keep wondering, the theory is if you invest in mental health, that you should save money in other areas, that you should save money in the sheriff's department, the jail, and the rest of it. So we did invest in mental health. Did we save money? And should any of that money be coming back over to mental health?
I don't know how to, if that's a question, I don't know how to answer it, right? Because I don't know how we would track like cost savings at a community level that way, right? But I do hear what you're saying too, right? That there's this idea, like for example, if you implement crisis now, ultimately the whole community will save money, right? Because decreased interactions with law enforcement and hospitalizations, jail times, and so on and so forth, right? I don't know, so, right? I'm not sure. And if there has been a saving somewhere else, no one is volunteering to send it our way. Let me put it that way.
Okay, thank you.
No more questions from the board? We're going to move on to our regular agenda and public comment. So does anyone want to provide?
My name is Paul Cumming from residential provider with treatment, and I'm kind of ahead of myself. I came to the board first, so I called the county to say we have a facility in Yuba City. So two things: I enjoy mental health board meetings, and please support the county when you visit them. So hopefully someday we'll be out of your service provider. So and I learned not to just glance at the agenda and go to the wrong building. Because you have the half hour you can drive.
Not alone.
Thanks.
Thank you for your comment. Is there anyone online that would like to provide? Nithya?
Yes, hi. Hi everyone. Sorry, I could not make it in person last month. But I just wanted to say thank you so much once again to everybody because last month was my last month with the local behavioral health board. I am applying to med schools right now. I've gotten a couple offers, which is really exciting. But I'll be starting in August. I haven't decided where yet because I'm waiting to hear back from all my schools before I make that decision. But I'm really excited to take what I've learned over the past year from the local behavioral health board and translate that to not only medicine, but also to hopefully get a master's in public health. So I just wanted to say thank you so much once again to everybody. And hopefully I will see y'all soon somehow.
Thank you, Nithya. We're gonna miss you.
Yeah, we appreciate your service on the board and good luck with everything moving forward from here.
And you're gonna be in an amazing position.
Thank you so much.
Yeah.
That means a lot.
Nithya, I really enjoyed working with you and getting a younger perspective on this board, because a lot of us are older. I'm retired, and I think having diversity of age is really helpful. And so, good luck going forward.
Thank you so much. And I'm hoping that'll continue with the younger perspective also by getting more Davis students involved. I am still in touch with people from NAMI at UC Davis. So I'm really trying to get them to come to these meetings whenever they can. But with school schedules and having access to a car, it can, or not having access to a car, it can be difficult. So hopefully they will join whenever they can. I'm really trying to get them to join.
Thank you.
Christy.
Christy, for public comment?
Hi, everyone. I'm making public comment on behalf of my son, Gregory Correa, who's here with me, but he doesn't feel comfortable speaking up himself. I really need some help from Yolo County HHSA. I've reached out multiple times to the behavioral health director, and this is stemming from an SDI claim that was filed on behalf of Gregory by his case manager, who at the time was Terry Lippold, who has retired now. And there was a federal SSA and SSDI claim filed back when he was in the an FSP patient, so he had Medi-Cal funding, and also MHSA FSP funding. And he wasn't in a physical or mental state to be able to operate these types of claims on his own. So he was getting help from his HHSA social worker case manager. And now that he has left the program in 2024, I've been advocating for him, and I'm now his SSA authorized representative. So the claim that got filed way back when he was in treatment there and in the mental health court diversion program is still ongoing. And now we have an appeal. And I've reached out to HHSA in writing and in person and let them know that Greg has an appeal date of March 26th. And we don't have his complete medical record. So now the administrative law judge is having to subpoena those records for us because it's been about a month and I haven't heard anything. And Gregory has been waiting for his SDI benefits because he had a job before he was incarcerated and went into the jail in psychosis back in 2022. And his SDI benefits are a benefit that he's been waiting on for years. And you know, he really needs them, and I don't know what else to do, but I'm basically using the sunshine effect here to get some help because there hasn't been any traction. I've been reaching out since October of last year to try to close this loop for him. But this is, you know, this is a benefit that he is entitled to, and this delay is causing him harm. So, you know, on an ethical note, I just feel like there isn't enough time and attention that has been paid to this. So, you know, I started reaching out to the forensic manager at HHSA years ago about this. And, you know, Greg still isn't in a place where he can advocate and navigate these kinds of complicated state and federal claims on his own. So I would appreciate if what has been said to me as far as meetings and things can be followed up on, and we actually can do something to help Greg with his SSA appeals case and his SDI benefits. Thank you.
Is there any other public comment? No? behavioral health director report.
Going through the whole thing, or do you guys want to pull specific items? What's the methodology with me?
This month, yeah, we're pulling enough items together. For the new first, Kingsley, what you do is you would look at the behavioral health and you would pull, say, I want section F, and you have a specific component. So there's different sections, and then if you're interested in this sort of process.
Thank you.
So I'm right for E.
I can pull D, please.
Just do one thing, just do house.
Any other suggestions from online? Like, what agenda items?
I didn't have anything this time. Thank you.
Same here.
So we have D, update in Public Records Act, E, Crisis Now update, and F, FSP update. Anything else? No? Okay, so we have D, E, and F.
Okay.
So we have a question.
Yes.
I was participating in the opioid coalition, so I'm just curious if any of these deaths were overdoses. Suicide could be an overdose, an opioid overdose. I know some are still pending, and I hope that when it's all resolved, I know we've had opioid overdoses in the past with clients. None of them are, that's a positive trend in that direction.
I cannot speak to that at this time.
Right.
I think part of the challenge here is that it's such a small data set that I'm really reluctant to speak on specifics, right, around some of the specific instances, right, because it's like small community and you can get into a situation that's like, I think that this person or that person. I was really struggling with the decision to bring this information forward. Not because I don't want people to know, right? I do want to be transparent because I feel like exactly Professor Shannon. I think that this is information that's valuable for the board to know and for the community to know. And so I'm struggling with that piece of like how much detail do we provide around like the specifics around the instances when it's such a small number. The decision to bring this forward was more around trying to assure the community that this is something that we are monitoring, and to, I mean, I think kind of respond to a narrative that I was hearing, right, around that, you know, all of these individuals who were in mental health clients were done, right, and as you can see, you know, we did have 14 deaths of mental health clients over the year, which is an average of more than 1 month, right? But you know, the overwhelming majority of these individuals were not because to your point, I'm reluctant to speak about the exact nature of what's.
We are the behavioral health board deals with addiction issues, overdoses. I have advocated the board last year for August for the proclamation on the overdose deaths of some of the residents in Iowa County. Doing outreach and awareness on this issue, so it's important to have that information.
Do we already have that information countywide? It sounds like this individuals already involved in.
The information is obtain, kind of depends on the coroner's report and what they test for, because they don't always test for everything. I think there's some work being done on that to improve what's being tested for.
So there is like public health data that exists, but the problem is it sort of lags, right? You know, so the most recent up-to-date information, like the state public health data website where you can like really information. So
You know what the lag is?
I don't know about something that I believe it's like sometimes like 2 years, right? Like we had some public health data that we brought to the board last year, I think, right? And it was a wow. Right? And I think it's because sometimes it takes so long to do the coroner's reports, right? Yeah. So this was our own query of our own data, right? So we have like what's called an unusual occurrence event, right? When these types of situations happen. So I asked our quality management department to go back and look at any client deaths that occurred in 2025 and compile this information. And sort of talking through this, there's some questions about can we compare this to other counties' behavioral health systems? And I don't know. I don't know if other counties are actively doing anything like this. You know, I chose to request that we compile this data set in response to what I interpreted as being public concern about an area that was out in the community about our clients dying because of self causes, right? So I'm not saying that I'm completely unwilling to, but I'm like at this point, like
But you don't have the answer right now.
Well, it's I've also been talking, right? Like, you know, it's kind of standard practice, even like at a state level, when you have like a can that's like below 11, that they don't even release the data. But there was a lot of internal conversation about whether or not we should do it. I feel that there's an overriding public interest in at least having this level of information, and that's why I want to share that. But you know, to your point, it is possible that you know, I'm not going to.
This is data that is accessible through writing a query, a data search? No, this is a hand search?
Hand search.
Yeah, so they basically look, because they do their self-report, right, but they, so say that they're there, and it's a sentinel event or and that's how we query it.
Well, the way no, he said he can't, he said he didn't query it.
Well, he went through calls.
Because if you, that's what I'm saying, if you can query it, then it doesn't matter how many there are if you can query it. But if it's a hand search, you don't, Public Records Act doesn't require you to do a hand search.
So this was less about complying with the letter of the Public Records Act request, right? I mean, and
no, but I think that's great that you, even though you had to do a hand search, we'll do the hand search and we'll be transparent.
So to be completely transparent, the Public Records Act request that we did receive was only asking for information. And I expanded it to give a more comprehensive. To your point, right? I mean, it's in this particular instance, it wasn't in my opinion, an unreasonable, you know, kind of laborious task of collecting information.
And there's quality data, right? So some of this will show up in quality data. Is a group that meets. And so, you know, all of us are invited to that meeting too. So that's another way. I mean, you don't really do it in detail quality metric. You talk in general. So that's another potential avenue for somebody on this board, really. You know, make sure that someone's coming back and reporting out from that group about what quality metrics are being shared. So that's another option that I can think of that might be, and I appreciate that Tony wanted to be transparent and trying to figure out because the N is so small and we had to go back through quality reports to figure this out. So we were trying to figure out how can we
how could we, the board, not wait 2 or 3 years and then, you know.
Well, my recollection from a couple of years back was that we did have the data on the fentanyl poisonings, some deaths. But of course, that was across the whole county, not specific. Not, you know, we weren't tracking how many of those were.
We're not sure specific or not, what life coverage is specific.
Yeah, yeah, it's very similar, like when you look at public health data, like related to suicide and stuff. You know, if these were individuals that were associated with mental health plan or like.
Well, do you think that this request came out of, I know it's hard for you to read the mind of the requesting party, but I know there was a period of time when in our collaborative reports, we had, you know, the N number wasn't large, but it was really challenging for staff and for the clients because we had a significant uptick in deaths of the clients of those programs. Is that part of this? Do you think?
I mean,
you know what I'm talking about?
I'm not completely familiar with what you're talking about, but what I will say is that my perception is that this was a concerned community member who had been hearing in one way, shape, or form that that our clients were
dropping like flies.
And there really isn't even a benchmark to compare.
No, there
I mean,
isn't.
one death is too much.
Yeah, right.
So
Right.
it's hard to.
Exactly.
Yeah.
No,
so
exactly.
I mean,
Yeah.
I will just say that with what I do know of the data set, it's concerning enough for us to really try to be monitoring and I now have an interest in like doing the same thing this year and like for us to be actively monitoring this and trying to, you know, when we have incidents, like take a better look at like, okay, what happened, you know, is there something that we could have done? Is there something that we could have done better? Right. But yeah, I believe that it was a concerned community member, and I think that there's another dynamic around this that is like where there's been some situations, like for example, where we have a former client who passes away for one reason or another, right? And so I think that there is the potential for there to be a public perception of like, right, this person, and I know that this other person died, right? And so we just wanted to be, because we received the PRA, right? Because it's already been something that we talked about publicly, I wanted to, we're sharing data so people can go, okay, at least I have some idea.
And the reason some of that could have been public, that there was a period of time where we stopped taking referrals to the specialty court programs due to a couple of overdoses. We want to make sure that there was sufficient case management for every person in the program to avoid that kind of situation. So that could be what perception was. If that was maybe in 23 when that happened, that if someone heard about that, they may think that there's a long-term program where it seemed like it was more of an isolated incident, because I've been involved in those programs since 2013. I don't remember ever having a spike like that.
I always have a concern of the severe mentally ill. You know, I mean, some of the accidents and stuff are as a result of delusions or hallucinations. And so I just wonder, like when you talk about 10 of these deaths were due to natural or accidental causes, to me, those are separate. You know, natural is just passed on versus somebody's having a delusion and they're walking a fine line on the road and they get hit by a car. To me, that is almost like suicide because they're delusional. You know, I've experienced that in my family with my loved one. It's been a big fear for parents like myself. And I belong to a group of mothers who have lost children that way. And so I wonder if that's not part of this as well. I mean,
so I can't speak to every particular incident, and there are sometimes when we don't have a lot of information, right? You know, we find out in one way, shape, or form that the person has passed, and then we may just get the coroner's decision, right? You know, on what happened, right? And so it's also hard to kind of parse out like that kind of detail, right? But to your point, I suppose that is possible.
or they've fallen asleep and they've frozen, you know, I mean, cold weather, no shoes. I mean, I've seen a couple of people just in the last month here in our West Sac, so.
Well, and to Chris's point, like accidental overdoses are frequently labeled accidental in the coroner's report. So.
That's a good point too.
I mean, so first of all, I appreciate the feedback, right? And I think that is something we can take another look at and see if there's a way for us to get a little bit better understanding of the data. Again, I think it would be, part of it is, I think, figuring out the right way to present this information to the community while still respecting privacy. And right.
I just want to say I appreciate that this brought up for you something that highlighted an issue that you now feel like is important to track. So I think thank you for that.
Well, and I also wanted to confirm that, it's hard to know. I mean, I think it's kind of hard to know, like, okay, do we have like a spike or a problem or something like that, right? And right now, I feel like, okay, at least I kind of have an idea of what's going on, right? And I think that not looking at it at all, we wouldn't have any way to know, right? And so now that we kind of open the box of looking at this, I think it's like, okay, like what can we do as a system internally, at least take a closer look at these kind of things and make sure that we understand what's going on. And like to your point, right? Maybe there is more that we need to be taking a closer look at and getting a better understanding. But yeah, I mean, just the question, once it was asked, is like, you can't unring the bell. I think, it's like, now do we have a duty to go and have a look and see what's going on? So,
Yeah, and I was maybe going to put that quality call because it's all the health plan on it and all the data. And it's a very interesting call. And it might be something somebody has a passion around, like quality metrics, which this would be one of those. It's a nice, I think every quarter. Yeah, so I can, I'll have it input, I'll forward it to you.
Is it Jennifer Gay? Yes. Yeah, Jennifer Gay is our quality manager, right? And so we can ask her to forward the invitation to the board members.
Yeah, and if you do end up doing it and you want to be it as part of your number report out, I know.
Stina?
Great.
Thank you.
Okay.
I appreciate it.
And just to clarify, so the 14 clients that passed away in 2025, that's just people that were involved with HHSA or the normal sources, correct?
They're active clients. Yeah.
That are active clients. So I guess like this is maybe an obvious question, but on a county level, in terms of the coroner, do they release? That would be the public health data.
There's public health data that's publicly released, but again, it lags behind.
Last time I was in the.
Yeah, so I mean, there's I forget what they call it now, like the Department of Public Health has like this system and it allows you to go in with a state level data or county level data. You can drill down, filtering certain visits, and there's all kinds of shit. And it's not just, around behavioral health and self-harm, it's
internal.
It's all kinds of public health information access. I have a feeling you have a project coming.
Well, perhaps. Any other questions about this online? No.
Okay, crisis now. Okay, so this has been something that has been just kind of a recurring standing item on the report, and we'd had some data on here, but it was kind of outdated, so I took it off there just so that we're not confusing people. But essentially, just the components of the crisis now are someone calls, someone to respond, right? A number to call, someone to respond, and a place to go, right? And so we've had the number to call and someone to respond for a while, but I will comment on mobile crisis response in just a moment here. But the receiving center has sort of been the missing element, right? And you guys have recalled all the twists and turns that have gone on. And really, the real update here is that we're moving forward and we anticipate that we're going to be able to have the contract with Wellspace Health and get on our own. And so staff are working on that. The contract's pretty much ready to go. The staff are working on the staff report for the board to approve it and allow us to enter the contract. But we're confident that we're pretty much ready to go. And then from there, there's, all the stuff you've already heard me talk about before, with piloting it and figuring out the system for referrals and how we're going to transfer the clients to and from. But we're finally there, right? I'm very optimistic that the next time we meet, I'm going to be able to tell you that we have a contract in place.
Same question on the contract.
Yeah.
Is it still at quality insurance or any
There will be some results-based accountability type data, right? Like all the contracts.
Yeah. Is there a way for us to kind of bizarre or to? So we create ad hoc committee that look at this and maybe look at other counties are doing with respect to now that we have a contract to see what data other counties might be tracking with respect to this. Or
Okay. That's a great question, right? I'm open to it. I think that right. I would love it, right? But right, right. But the contracting process is very, very challenging, with the county, right? And there's like all these different elements. We now have another process we have to employ through 8239, right? So we are now required to notify employee unions if we're contracting out services that could be conducted by employees, right? And so I would love for the behavioral health board to be involved in looking at, like for example, we try to include you when we do RFPs, and I would love for you to be involved in helping us to establish quality metrics, right, for these contracts. As long as it doesn't delay the contracting process, right?
Yeah.
It's a great idea, right? And I think it's also a good way for the board to be more closely involved and get better understanding about how all that works,
Right. So a couple of things, because ad hoc committees are, time limited and very specific.
Right.
And you talk about how there's just not a lot of staff. You've got a lot of going on. So not wanting to mess it all with the contract.
Sure.
Piece, but there are people on the board that are passionate about crisis services.
Yes.
And so if we as an ad hoc committee, did fact finding, to say what are some of the other counties that folks do that may be similar and what measures are they finding helpful or what are their lessons learned from tracking data. That's more where I was going, not to get involved in inside, but.
So the only dilemma I see here is we're trying to kind of get across the finish line right now. And the outcome metrics need to be a part of the contract that we're going before the board. Right. Right. But here's what I will commit to doing is I will have the lead on the project reach out to you tomorrow. Okay.
When you have the contract signed.
Oh, okay. Okay. All right.
What's the time frame for the contract?
So what we're proposing, so we were, initially it was supposed to be a 1-year pilot, right? Starting in March and only going for a year doesn't make sense, right? So we're proposing to go from March of 2026 all the way through to July of 2027, right? So just basically trying to end it on the fiscal year so that depending on how the pilot goes, we can make a decision about extending the pilot or what we do, right? So
we're expecting the contract in place for March.
We're expecting to have the contract in place for March and to go to June 30th of 2021.
Yeah, so part of our fact finding is once you have the contract, we can look at the business and then maybe the thought might be is to reach out to other counties and say, hey, is there anything else we should be?
But there's nothing that prevents ad hoc committee now reaching out for different metrics and bringing that back.
Right, but it would make sense if we had what metrics we know that Wellspace or whoever is obligated to already provide, then we can maybe validate, the contract's contract, we're not trying to change that, but, I think there's just enough passion in this group and people that we would love to help kind of make sure we're going in a direction, especially knowing how overburdened you guys are. And a lot of people like to do fact finding.
I love the idea.
Yeah.
You know, I mean, I think it's a great idea. I mean, you don't have to limit it just to this contract, but we can, you know, if you want to take a peek or have input on, you know, outcome metrics for future contracts and stuff. You know, I don't think we should close.
Once the contract is in place, then we'll visit.
Okay.
And see who wants to, see if the same people are interested.
Sounds good. Yeah. The mobile crisis response, we have, you know, as you know, we released 2 separate RFPs and we haven't received a proposal that has resulted in a contract. And so we've been extending this contract with AMR for a while, right? And we're looking at just basically extending it through the end of the fiscal year. But what's relevant with mobile crisis response is the governor's budget is proposing remove mobile crisis response as a mandate for the behavioral health, right? And essentially that is a financial strategy by the state to release themselves from the liability of covering the costs that are associated with it, right? So as it stands now, when we do mobile crisis response and we provide the service, we're reimbursed for the entire amount of the medical clinical, and so the state's covering the national charity trust and other things, right? And the reason for that is a requirement for the state, like a top 30 issue, right? And so now the governor is proposing to say, I'm not going to mandate counties do anymore, which means that the county would incur costs, right, associated with the response, right? So we would have to provide the match funding, and we'd only be reimbursed for about half the month we do, which creates a dilemma for us when we're in this financial situation that we're in. Do we want to propose to continue to provide this service NSO, right? So I'm just putting this on the board's radar right now, because that is going to be a potential decision point that needs to be made for next fiscal year.
Can I ask a clarifying question?
Yeah, 100%.
Is that when you talk about the responder staff in here for mobile crisis, is that who responds to school sites for mobile crisis? Because it's during the
so yeah, let me tease some of it out, right? Okay. So the mobile crisis response benefit is a 24-hour response, right? That we're required to have. The crisis co-responder team is a partnership with the cities and the probation department and county sheriffs. And then we have another grant that we were using to have some specific responses to the school sites, but it's being performed by the crisis co-responder. I cannot anticipate a scenario where we would be ever advocating to dismantle that, to dismantle all of that, right?
That's why I'm wondering what you're paying. If the county incurs the cost, if it's also going to impact the system.
I don't know, right? But like what I can tell you is that I cannot anticipate a scenario where we would dismantle the crisis correspondent. The cities are sharing the cost, right? That's well established. It's been very well received. What I see as a potential decision point for the county to make is what to do after hours.
Okay.
Right. So
just saying it's working well for Davis in particular. So I would like that not to go away.
Yeah, we've heard all positive things about our crisis co-responders, right? That the challenge for the county is really financially in terms of how to meet the obligations of providing the services after hours and on weekends, and the amount of money that we're expending to meet that mandate, and as opposed to the amount of revenue that we're able to generate and funding. So we may have to make a decision about whether to provide those services after hours on weekends, if it's not going to be funded related to now by the state. Yeah, yeah, I mean, the RFPs are, the challenges that I think that we're experiencing with the RFP is like what we're wanting is for a provider to be able to have like a clinical person who can do a med account, right? And so the providers that have kind of expressed some interest are more inclined to want to do the response part and not have like the clinical person. Right. To date, right? I also don't know that they're I don't know if the amount of money to be available really makes sense to sort of the providers.
And I just want to make a comment on that because I did send and read these RFPs when they came through. And I noticed like, okay, one submitted, they said there was 3,198 after hour calls, right? And they needed 11 and a half staff. But I looked it up online and I was looking at some of our information in Yolo County and I found only 820 actual after hour calls. So I hope that we're verifying and double checking some of those numbers, because that's really far off, 1820 versus 3198. After hour calls.
I would have to look at.
And I gave my comment and my feedback on that before, but that's just a point too, like really 11 staff to do that?
To cover like after hours and weekends for the entire year. Well, so there's two separate questions here, right? One question is, would you need a staff of 11 to do that? Probably. I mean,
and what is the actual number though? Let's look at what the actual number is first before we determine how many staff, right? If it's 1,820, that's the actual calls we're getting, and they're submitting and saying that Yolo County is, it said in there that Yolo County is actually responding to 3,198 after hours calls. Yeah, that's like what, 57%.
I would imagine though that the county is, the way it's situated is broad, right? So you could have multiple crises occurring and then you have people in different spaces there.
So what I can tell you is that we believe that we believe that the service is underutilized. However, part of the challenge has been around like what we would expect to be the referring parties after hours would be like largely law enforcement, right? And there's been some different efforts to engage law enforcement partners, and they've been very, clear, right? That like the expectations that we call you to get out, like get right out here, right? And that if that doesn't happen, then an officer is not going to like potentially, right? So we're trying to work through some of the law right now. It has not been an awful lot of calls, right? I can't speak to the exact numbers depending on what time frame we're talking about, right? But what I can tell you is that with the solution that we've had with AMR, which is very expensive, and they have done a great job. It's not their fault that we don't have a call volume, right? But like, it's very expensive, and for the amount that we're getting reimbursed, we're losing money, right? As part of this, right? So if the state is not going to mandate it, and we're going to receive even less revenue than we currently do now, then we're going to have to make a decision about how we proceed and whether or not we're going to be able to continue to do this 24/7.
That's the government's recommended budget, right?
That's the government's
So it's got to
recommended
go through the
budget.
legislature.
Yeah, no decision has been made on that. Yeah, it's just something we're keeping an eye on. Yeah. Really? Oh, okay. All right. You look like you really.
Where your thoughts go on that?
Okay.
Just thoughts when you're like, this is beyond our scope. I'm like, is it? But, okay.
Okay, we're ready to move on to F?
Yeah, it's a quick question. It says, HSA is continuing to meet with housing partners.
Yes.
We had discussed maybe inviting them to speak. Is that something we should consider?
Yes, it was.
Okay. So we'll, maybe we can invite them the next meeting. As a speaker, event on the housing as it relates to FSP. The Yolo County Housing Authority. There's been a lot of questions from this group, and so I just want to make sure.
Yeah.
That I. And if anybody has any members having objections to having that.
Does that cover the tiny homes?
Yeah, the permanent supported housing sites that were specifically supporting our West Beamer, which is right across the street from HSA, the tiny homes, the East Beamer project, and then the West Apple.
I'll make sure I.
Yes.
Because at the last opioid coalition meeting, there was brought up that there is a significant drug problem in tiny homes. Guess that would be something. There was a report, put it that way.
I've heard various rumors about all three of the different sites, right? You know, and I'm reluctant to talk about rumors and stuff.
Okay.
What I can tell you is that our permanent supportive housing partners are saying that they need more support from the county than they are currently receiving.
I'm sure there'll be questions. There's a presentation about this, because you know, from past experience, you've had people that weren't competent to stand trial, and back from that State Hospital, but then housed at room board, and then moved into the Mercy housing where methamphetamine was, stopped taking the meds, started using methamphetamine again, committed new crimes, you know, back in State Hospital. And we have a cap on the number of people we can send there before the county gets bills. I just have a concern and hope that trend has changed or not. And if they do a presentation, there'll probably be questions on that.
So I can't speak to I will let the housing partners provide their own perspective on what's going on. What I can tell you is that what I'm hearing from my team is that we're not completely aligned with the philosophy, right? And that the contractor provider that we previously had with us supporting the sites was doing some things that we wouldn't necessarily do. You know, our staff are very focused on helping individuals work towards being independent and self-sufficient, right, to be possible. And we're hearing that our contract providers are kind of doing, now again, it's FSP, so it's whatever it takes, right? But then it was becoming more about, like, for example, like paying someone to own things homes and helping them to learn the skills that they needed to clean their home and to doing like all kinds of interventions that like we would do it a different way. The other thing I'm hearing is that we believe that we were having individuals placed in some of these units who were really not ready to clean it, right? And so, you know, for all intents and purposes, it's like you have to do all this incredible like work to try to support someone like that who's not quite ready yet and who may be vulnerable to.
Well, I would agree that was happening, right? Because
and so then they're essentially set up for failure, right? Yes. And so we're working to correct some of that, right? And being involved in sort of the decision-making process about who is going into those things, right?
I think there's pressure to put a certain number of FSP clients in Mercy housing to do some contract obligations when they weren't ready.
Yeah.
And there's only so many FSP spots, right? And so we just want to make sure, the board, I would think what we've heard is we want to make sure we're using them as efficiently as possible.
And then people get an addiction on their record and it's permanent.
So just want to make sure everybody's okay with that. That's our next speaker. We'll invite them if they can come.
I'll make my try.
And if you have some questions you want to, Chris, if you have some like questions you want to send to Christina that she could let them know, hey, could you
Okay.
please address this? Then
Happy to collect them.
you can, and welcome anybody. You have particular.
I think the drug use issue in those locations, because it brings other people down.
I think one of the, I mean, you know, without trying to carry too much of a bias and assumption in, right? I think one of the unique challenges about tiny homes is we have like a transitional shelter there as well, right? You know, and it's all, everything's kind of all on the same site, right? You know,
One of the challenges is a lot of the individuals in the tiny homes came from homelessness.
Yeah.
Their friends are homeless. And so the friends come and hang out in the housing with them, bringing their issues in there also, which makes it a challenging place to manage.
And right, I think that like, that's part of our work is to kind of help people be prepared, right, when they're working through addiction, to be able to be setting boundaries, right, and doing that kind of work, right, you know, so I think that those kind of dynamics are always going to be present for the clients to be served, right? It's just, you know, what we can do to support them.
Next, Tony. We're going to ad hoc committee reports. That is the second.
Yes, we do. I'm gonna miss Cynthia. I'm still there, Cynthia. He's gone.
She had to leave.
Yeah.
Okay, well, if you guys remember, we put together a process. The ad hoc had the goals, we've done all of our goals of creating the process that we brought in November. You guys have that. We don't have a copy here tonight. We shared the process with you guys. Everybody was in agreement, right? That was part of our goal. We talked to Tony, we met, come up with a process to obtain the contracts with the providers, and then a process to contact them. And Tony and his staff will be the ones that will call the visit. So with that being said, now we
I have a
just have to
scratchy
go on
throat. I'm a little worried about it. Yeah, I just realized.
Really, you need it there.
So basically, we've completed all the tasks that the ad hoc put together. And so now the next phase would be actually going out and doing our first site visit. I will say that the contract was pretty long. It was 100 pages, less than 100. So basically, you know, I kind of went through it, and there is a scope of service in there. And so I kind of focused on the scope of service. So it won't be too cumbersome if anybody wants to join the next ad hoc. Is that something we would do?
Yeah, so we're gonna close the ad hoc, that fact finding, right, the time limited, which was to validate the process, create the process, come up with a process with the county. Done, which thank you, that's amazing work, and build on what the previous ad hoc did. So this ad hoc closes, the next ad hoc is really a site visit. And so, does anybody want to, I think Melanie is willing to continue to chair through this first site visit. I would be great if someone could co-chair with her so that there's another person, and so then there'll be another site visit after this one.
And volunteer for that.
Okay, well,
great, yeah.
Okay. And I know Dee has volunteered each and every time she's got here tonight, so she would like to.
What's that?
You're gonna go to a site, so they'll do
Yeah,
a site
yeah,
visit. You'll go to the site visit, then report back, the fact finding on the site visit.
So creating this new ad hoc, the last one we had a chair and a co-chair. Do we need to do all that, or do we
I think
just?
you're the chair, he's the co-chair.
I'm gonna be the chair?
Yeah.
Okay. You're gonna be?
You're the experience.
Okay.
You do
And then after this one, then you can, if you wanna pass the torch, then you can.
Okay.
And so then this ad hoc is for the purpose of doing
The site visit.
site visits in 2026.
This site visit, yeah, this site visit, this particular site. visit.
Okay.
So what I'll do is I will forward the contract that we got from our person. I can't remember her name. Tony, the gal that you assigned us.
Was it,
But I'll look at the
was it
email.
Johnny Laura Jimenez?
I think so.
Yeah.
So I'll forward the contract for Safe Harbor, and then I'll get in touch with you, and so we can send the paperwork over to them.
I think I saw an email from one of you. yesterday, I just haven't had much.
Yeah, and the reason why we can't, because otherwise it's a standing committee if it goes after the end of the year. So we have to,
Okay.
so that's why it's ad hoc, it's time limited, it's very specific. And then there'll be another one once the site visit's done, the next site visit.
It might be, you could have an ad hoc meeting for 3 site visits or, no, okay.
Well, I asked, I was told it would have to be much more time limited than that.
Okay.
So I was good with that, but it's not.
Hours it be?
How would it be? Yes. So I can, if you want to, Howard to be the attorney talk, I'm good with that. Maybe I didn't ask the right question. So anyway,
We'll get one of these.
we'll get through it.
And I think it'll be important to have that for the next annual report.
Yeah. Yeah, because we should be doing at least 3 if possible. Maybe looking 2, but we can do 3 hours. I mean, and then if there's tours, that's separate. You know, I mean, there's tours that happen. Then that, you know, those can still happen. It's just not part of this work.
And you don't need an ad hoc committee for tours.
Correct.
Okay.
Did Sue or and you want to join the committee, the ad hoc committee?
Yeah.
So oh, sorry. Go ahead, Kenya.
Sorry. Yeah, I had signed up previously, so I'm interested in the next site visits if possible.
How many people can go on each of these?
Well, since we're doing an ad hoc for just one site visit, right now we're at 5.
Okay, so
I think it's good to have 5, but I don't know if all 5 of us should go. So I guess we can, yeah, we can determine. I'll send everything out to you guys and then we'll come up with the date and then some of us may not be able to go on that frame.
Oh,
So,
okay. Can you put me as an alternate?
You have an ideal number for how many people you're planning on actually going on these?
with you 2 3.
3?
Yeah,
I can be a multiple.
okay. Thank you.
I think that the point is, let's say 3 go this time, but 2 couldn't go, maybe they go to the next one.
Okay.
Yeah.
It's a new
But I think
process
2
for us.
Yeah, it's great. Yeah.
I don't want it to be overwhelming.
Yeah, I agree. And there's gonna be a little work involved.
Yeah. Okay. Thank you.
Bye.
Thank you. Now annual report ad hoc committee leads me.
So when talking with the rest of the annual report ad hoc committee, we kind of came to an agreement that I was going to do a high level overview of the recommendations we're going to put in the annual report because a lot of the annual report really is just fact reporting. So for example, going through past agendas and just looking at our attendance, reporting out like things that we've done, such as create the process for site visits, things like that. So a lot of it is just facts. So that the part that is kind of more up to board determination and interpretation is the key concerns and recommendations we're listing at the front. And so I wanted to provide like a very, very, very high level overview of that. So board members can bring up any concerns and suggestions before we bring the full completed annual report for board approval next meeting, so the March meeting. So I'm just going to read through it. And then if anyone has any questions or wants to provide any feedback, we can discuss this in the time that we have left. So first, the first recommendation we had was to improve data sharing and accountability. So our concern was that fragmented data systems can limit transparency, accountability, and the county's ability to fully assess outcomes and plan strategically. Our second main recommendation was maintain and develop services for vulnerable populations. Our concern was that service demand continues to challenge available capacity, particularly for individuals with the highest levels of need within a constrained funding environment. Our third recommendation was to advance crisis continuum development. Our key concern regarding that was that the mental health crisis response system continues to evolve and would benefit from further alignment and integration across settings. Our fourth recommendation is to strengthen children's mental health services, as children and youth may experience service gaps during transitions, particularly between school-based and community-based services. Our fifth recommendation is to enhance coordination with community partners. And our sixth recommendation is to address housing and homelessness, as behavioral health related housing and homelessness funding is complex and continued clarity may support effective use of these resources. So that's just an extremely high level overview of the recommendations and the concerns of why are we establishing these recommendations that we're going to put in our annual report. So if there's any feedback, anything you should add, adjust.
It's a lot. Anything else to add to it?
I think your report.
Okay, Tony. Yeah, so essentially kind of our process for doing this is we, as an annual report committee, we went back and we looked at agendas, minutes, things that were brought up in presentations, things were brought up by members of the public over the last fiscal year, and so 2024 to 25, and then over the last few months of 2025. And we kind of came up with this compilation of concerns and then things that people have brought up. So that's kind of our process for kind of how we refine this. So we just wanted to kind of be transparent about what we're going to say before we finalize this next meeting.
I guess the question is conceptually, it does have an issue, right? Because there's something that we should consider, either maybe removing or adding.
Is there any way you could email that to us and give us a chance to kind of think about it? No? Give us maybe a couple of days.
Yeah, so kind of by bringing it up now, we were able to kind of communicate this to members of the public and also to the board and give kind of advancement.
To what degree would you like my input?
In the sense of historically how that's.
Why not?
I have one question. So I think it was the fourth item. You said something about enhancing relationships with community partners or something like that?
Yes.
Do you mean for the board or for the behavioral health plan?
Behavioral health plan.
Okay, all right, I understand. First of all, I appreciate all of this. And I think that you have done a great job of assessing like some of the real critical issues that are facing the county. So I certainly have no objection to your recommendations. The only thing I would respectfully ask is if there is something that you notice that we're doing well, could you also include that too?
Oh, absolutely.
Yeah. Because I mean, I think that the thing is we want to be responsive to what the community desires, right? But I also think that it's really important for us to be recognized for the good.
We're not just starts.
I assume.
But I appreciate it.
And I would say that one of the major challenges is with Oak Cooperative not keeping a contract. What the staff has had to do, and I think that there's challenges with that, but I think that what I've heard at times, response was positive. So I think that may be something to include in the report.
You mean that?
Oak Cooperative is providing the FSP services, the case management services.
And then they didn't. And that was positive.
No, the way the county staff responded
Was positive.
They've done
They did
a very challenging job, and they stepped forward, and it may
It was
not
a
be
heavy
perfect,
lift, yeah.
but it was something that definitely stressed county staff, and I think they've done.
I think I think if there is one thing you could possibly call out about past years, right? I mean, it was probably the most difficult time of my professional career where like I had to, well, not I had, like I was responsible for something. I was like, I didn't see how we were going to do it, right? You know, and I was very worried that it wasn't gonna, and it's not because of me, right? You know, so I'm just putting that out there.
No, that's a great one. We did all that
The
up.
forensic team, the access team, those teams had to pick up the slack, so to speak.
There's people on the call listening right
I was just gonna say that.
who are the real heroes, trust me.
Yeah, no, we're in a lot of everything that everybody does.
But aside from that, I mean, aside from like what we figured on, I agree with this. I think the other thing, how can we support you and development of it? This is something that we should be that the board should be presenting to the board of supervisors, and just let us know when we think we're ready. Start. We'll assist you with the process of getting on the boards together.
Sue has her hand up.
I'm not sure if somebody already said this, but just to be clear, those are the recommendations. And so there's a whole state of the county mental health services that's going to be talking about sort of what's been going well. And that would be the right place for some of what you're talking about right now. So we'll be bringing back, maybe you already said that. I couldn't hear because of the Zoom, but we'll be bringing that back next time.
Thank you, Sue.
So I think the goal, and I'll probably need Christina to help with this, is that instead of this going out to the draft going out to the Friday before, because that doesn't give you a lot of time, is there a way for the draft to go out sooner? And it could certainly go to the public too, Christina. Is that something you could post?
Are you wanting it posted online for review or just sent to other people specifically?
I want the board to have more time than just a few days to review the draft, but I know the public needs to get it at the same time. So I'm trying to figure out how we can coordinate that, and maybe we can talk.
I mean, I can post it to the website. Everyone would have the same access to the
I think that's
local
what we're gonna
behavioral
have
health
to
board
do.
website. Yeah.
So I think that's what we're gonna do so that the board has more time to review.
And since it's the annual report, I can actually pull it out so that it's highlighted in the
And put
webpage
draft.
for review
And put draft.
as a draft. Yeah.
So is everyone okay with that?
Yes.
Because that would give you more time than the traditional Friday before the next meeting. Because it's a lot. I mean, some of it is like she said, it's very elementary and just statistics, but there is quite a bit. And since we haven't done this level of a lift in a while, just want to make sure everybody has a voice.
I mean, that's fine, but the only thing I would say is, in terms of the Friday before, the time frame for the Brown Act, you can post earlier.
That's what I'm saying. That's what she's gonna do.
Yeah, you just can't post it, because when you said Friday, you don't have to.
Right, so instead of us doing it on Friday, like we normally do, I want to give people more time.
Yeah,
So,
perfect.
but I
I'll
want to
post it whenever you give it to me.
But I want to make sure Christina had time to do that, because that's
Yeah,
something she has.
yeah.
So,
If we review it and we have comments for the committee, Brown Act doesn't prohibit us from sending Kimberly an email.
I think it does.
I can collect all of your feedback
Yes.
and share,
I'm just trying to.
but it has to come to me.
But yes, I appreciate that. Yes, so you would send it to Christina.
Okay,
Yes.
this process wise,
That's a great
since I've
question.
been on the board, we haven't done this, so
That's a good
Yeah.
question. Yes.
I definitely wouldn't want to violate the Brown Act.
Yeah, this took a lot of consultation with through Comstock and then people from other boards about that have done annual reports in the last year or two to kind of get context on like how does the process go, how does the structure go, what's typical, what's not, what's included.
Right, so I think our goal would be to get it to you guys by next Friday, but it might be it might be 2 weeks from. You might have a week. You might have 10 days to review, because February is a short month. So.
How long is the draft, just out of curiosity? This is, yes.
It's like, 14.
Okay.
It's not, but that, yeah, it's just, it's not that it's the length, it's just the stuff, it's just a lot of dense.
Yeah, but because there's so essentially what I brought up was just a very small section of the report, and it's the kind of things that are more up to word interpretation, so key concerns, recommendations, but then there's a whole section of status of behavioral health in Yolo County, and then there's status of behavioral health board, and then goals and accomplishments is a very like template heavy section, because there's a template provided by Cal VHBC on what we fill out for that. So then that's quite a few pages of the report. That's the template from Cal VHBC.
Okay. Is there information in there about the data notebook?
It's mentioned.
Okay.
We don't have a link.
Okay.
Yeah.
All right. I mean, I think it's just important work that you're working on. Yeah, that's your.
All right,
Just,
so great
I'm just
question.
asking.
So you'll get it out, you'll send your comments directly to Christina.
Is this after I post to the
After you
website?
post it, yep.
So what I'll do, once they send me the document and ask me to post it, I'll post it and I will send an email with the link to the annual report and the website, so you know when to go to look at it. And do you want me to send that out to the interested parties as well? So that everyone's notified at the same time that it's been posted?
Sure.
Okay.
Yeah.
Thank you to Kimberly running your first meeting. She did an awesome job.
Public comment?
And we're, yeah, you should just, okay. I just want to say thank you. I forgot.
Appreciate it. Public comment? Okay, is there any online public comment? Okay, well,
Motion to close.
yeah, motion to close the meeting. All in favor, please say aye. All opposed? Okay, well, motion carries, meeting now adjourned at 8:01.
Well done, Kimberly.
Thank you.
It was not anywhere, but that's working on. That's great. Well, I'm.